Namaste Vidya. Myself, JV'n Dr. Ravi Jain, Assistant Professor, Department of Practice of Medicine, in Faculty of Homeopathic Science at JAYOTI VIDYAPEETH-FHS University, JAIPUR. In today's lecture, we are going to continue with another important topic of the locomotor system, that is ankylosing spondylosis. Ankylosing spondylosis is basically a disease that is more commonly affecting your spine. Okay? And this is another very important disease that is affecting a lot of people and a lot of population. This is not easy to diagnose, but once you see the X-ray and the clinical features, this is a very important disease and a very interesting disease to study. So let's start with ankylosing spondylosis. What is ankylosing spondylosis and how is it different from the symptoms of arthritis, especially osteoarthritis and rheumatoid arthritis? So let's start with the disease. What is the definition of ankylosing spondylosis? Ankylosing means fusion. Alright. So here what is happening? There is fusion of the intervertebral disc, which is restricting the mobility of the spine. So this is basically an inflammatory disorder. So inflammation is also present in ankylosing spondylosis, as we have seen in case of rheumatoid arthritis. If the inflammation is present, then what are the symptoms that will be there?
Rubal tumor, calloid, function.
Very good. There are 5 signs of inflammation. Alright. That will be present, and the cause is unknown cause. The exact cause is unknown, and it is usually affecting the axial skeleton. We have 2 types of skeleton: peripheral skeleton and the axial skeleton. So the axial skeleton is the central part of the body. Right? And this disease is particularly affecting the central axial skeleton of the body. Some of the peripheral joints are also involved, and extra-articular structures are also involved. It is basically a chronic arthritis. Alright, so it is also affecting the individual for a longer period of time. Chronic inflammatory arthritis, because inflammation is present. This is an inflammatory disease. RA was an inflammatory disease, and in case of osteoarthritis, inflammation was not present, which predominantly affecting the sacroiliac joint. So the most common joint that is affecting is the sacroiliac joint, which can progress to bony fusion of the spine. Therefore, it is known as ankylosing spondylosis, because the sacroiliac joint is present and ankylosis is the fusion of the vertebral column. Now, this is the X-ray. This is the picture that clearly resembles a bamboo. Therefore, this disease is also known as a bamboo spine. Alright? The vertebral column is fused totally, and this appearance is similar, very similar to the bamboo. Therefore, it is known as bamboo spine disease. Now, ankylosing spondylosis basically belongs to the family of spondyloarthritis. Spondyloarthritis denotes the various diseases which are having common symptoms of arthritis. So, all those diseases which are having the symptoms of arthritis and are having common features belongs to the family of spondyloarthritis. The other diseases present in the spondyloarthritis includes reactive arthritis, we have psoriatic arthritis, enteropathic arthritis, generalized onset spondyloarthritis, and undifferentiated spondyloarthritis. Now, spondyloarthritis can be of 2 types, one affecting the center and the other affecting the periphery. So the center one is the axial, and in the axial we have ankylosing spondylosis. And we also have other type, that is peripheral spondyloarthritis. So depending upon the type of joint involvement or the type of the pattern of involvement in the body, we have axial spondyloarthritis and we have peripheral spondyloarthritis. So in axial we have symptoms of chest, spine and hip bone. Whereas in the peripheral spondyloarthritis we have symptoms of finger, knees and toes. So this is the basic difference. Now, ankylosing spondylitis usually begins in the 2nd and 3rd decade. So, in 2nd decade, what is the age group in 2nd decade? 20. No. 1st decade is from 0 to 10. So, 2nd decade will be from 10 to 11 to 20. So, this is again even more younger age group. And the 3rd decade is
21 to 30.
So this way it goes. So it is mostly affecting the people between 11 and 30 years of age. So ankylosing spondylosis is even affecting more younger individuals even as compared to rheumatoid arthritis. Male to female ratio is between 2:1 to 3:1. So it is more common in male population. It is commonly known as the axial spondyloarthritis. Now you know why it is known as axial spondyloarthritis, because it is affecting the center part of the body, the spine. And there is great association of HLA
B27.
So if it is asked from you which disease is associated with HLA B27, so you always have to know this ankylosing spondylosis. This is a very important thing that is usually asked in the examination. Name the gene or the genetic predisposition for ankylosing spondylosis. So you have to tell HLA B27. In case of rheumatoid arthritis, for HLA BR4. So this is basically HLA associated gene. Yesterday someone was asking from me the genetic diseases. So these all will be considered under the genetic factors that are responsible for development of different types of disease. What is the full form of HLA?
Human leukocyte antigen.
Very good. Now, what is the pathology? What are the different changes that are occurring in the human body in case of ankylosing spondylosis? You all know the outcome. What will be the outcome in case of ankylosing spondylosis? There will be fusion of the vertebral column. Alright? So, all those changes that are responsible for the development of fusion will be discussed under pathology. This is an inflammatory disease. There will be inflammation. There will be signs of inflammation. There will be formation of panels, as we have seen in rheumatoid arthritis. So there will be formation of panels. There will be ossification of the cartilage, leading to the fusion, the formation of the bone and fusion of the vertebral column. So all these changes will be discussed in pathology. So sacroiliitis is the earliest manifestation. So the earliest manifestation that is seen in case of ankylosing spondylosis is sacroiliitis. What is the meaning of sacroiliitis? Itis is
Inflammation.
and sacroiliitis means so this is sacroiliac joint, and there will be inflammation at this particular place. There is inflammatory granulation tissue in the paravertebral connective tissue. The granulation tissue was known as Pannus formation. Okay. At the junction of annulus fibrosis and vertebral bone. I will show you the anatomy of the vertebral column so that you can recall the annulus and the vertebral bone. In the next slide, we are going to see the anatomy. Remember annulus fibrosis and vertebral bone. Now, first of all, let me show you annulus. You all know this structure?
Yes.
So this is the annulus fibrosis. Alright. And this you all must have made in the anatomy class. This is annulus, this is intervertebral disc. Alright. Nucleus pulposus. Just remember these things because this is going to come in the pathology. So in order to understand the pathology of ankylosing spondylosis, you should recall all these structures of the vertebral column. We have intervertebral disc. This annulus, they have nucleus pulposus, we have spinal cord, there is superior articular facet, spinous process and transverse process. So these are the processes of the vertebral column, as you all know, and they are fitted one by one. And there is fusion. Can you see this thing? The changes that are happening in the vertebral column. The outcome we already know, there will be fusion of the spinal cord. There will be ossification. So these changes we are going to discuss here. Now, there is an inflammatory granulation tissue in the paravertebral connective tissue at the junction of annulus fibrosis and vertebral bone. So now you know what is annulus fibrosis. The outer annulus fibrosis. The fibers of the annulosus are eroded. So there is erosion. In rheumatoid arthritis also, before the fusion of the bone, there was erosion of the bone. So first of all, erosion takes place, then pannus formation takes place, then ossification, and then ultimately fusion takes place. So the fibers are eroded, eventually replaced by the bone at the beginning of syndesmophyte. Alright. A syndesmophyte then grows by continued endocornal ossification. This is the formation of syndesmophyte. Alright. And what is happening here? Endocornal ossification, ultimately bridging the adjacent vertebral columns. So there is bridging, formation of syndesmophyte and bridging of these vertebral bodies and then ultimately ossification in order to make the vertebral column immobile. So all these things are happening in the pathology. These are the changes. Now there is ascending progression of this process leads to bamboo spine. This process is an ascending process, and when this process is complete, ultimately you will get a bamboo spine that you have seen in the X-ray. Alright? The changes that are taking place. This process leads to bamboo spine. Other lesions in this spine includes diffuse osteoporosis. Apart from fusion of the spine, there is also osteoporosis, that is reduced concentration of calcium in the bone. Erosion of the vertebral body at the disc margin. Because of the erosion, usually the shape is oval of the vertebral body, and because of the erosion, it becomes square shape. There is constant erosion of the vertebral column and formation of the syndesmophyte, which is causing the fusion of the two vertebral columns together. This leads to the squaring and barreling of the vertebrae. Due to the squaring shape of the vertebral column, it is appearing like a bamboo in the X-ray. Alright, so there is squaring, there is formation of barrel. Inflammation and the destruction of this bone borders. There is inflammation and destruction of the bone borders. Inflammatory arthritis of the apophyseal facets joint is common. Erosion of the joint cartilage is by pallus is followed by bony ankylosis. So first of all, there is formation of pallus and then fusion of the vertebral body. The inflammation in the fibrocartilage anthesis. What is anthesis?
Inflammation of
Anthesis.
tendons.
Anthesis is basically the point where the tendon or the ligament joints are attached to the bone. That particular point. Suppose this is a bone. This is a bone and this is a joint, and the point where the ligament or the tendon is attached, that point is known as anthesis. Alright, this term also occurred previously, and where it was known as enthesitis. Inflammation at this point is known as, yes, enthesitis. So this is anthesis basically. So inflammation is there on the fibrocartilage anthesis. Now, the pathology was a little bit trickier one. I don't believe that you can understand this in one go. Just go through the pathophysiology again from the book, and then it will be more clearer to you. Alright. So pathology was a little bit tricky, but after going through your book once again, you can clearly understand it. Even if you face any kind of problem, you can ask me tomorrow about this pathology. Alright. So pathology, you just have to go through your book once again in order to understand, because in the book only small pathology is written about this particular disease. Now we come to clinical manifestations. What are the clinical manifestations? Clinical features that are seen in case of patient with ankylosing spondylosis. What are the clinical features with which a patient is coming to us? So the course of disease is extremely variable. So as the disease progresses, the symptoms also vary. So the course of disease is variable. When a patient of ankylosing spondylosis is coming to you, then the course of the disease will be variable from very few symptoms to complete fusion of the spine. Alright, so there will be a great variety of symptoms that can be seen in the patients, ranging from the individual with mild stiffness. In the earlier stage, there will be mild stiffness of the spine and normal radiograph. There will be no change in the radiograph that will be seen in the early stage. So the patients with totally fused spine. So if the patient is coming to you in the early stage, there will be slight stiffness and there are no radiological changes, no X-ray changes in the body, which could point out about the ankylosing spondylosis. But if the patient is coming in the later stages, there will be complete loss of movement with radiological changes that resembles bamboo spine. Totally fused spine, severe bilateral hip arthritis because of the sacroiliac joint involvement. Both sides of the hip will be involved. Alright. And extra-articular manifestations that will be seen in the case of ankylosing spondylosis as well. The constitutional symptoms, what are the constitutional symptoms?
Fever, fatigue,
Fever, fatigue and weight loss. Constitutional symptoms are almost similar in all the diseases. We have fever, we have weight loss, we have anorexia, we have all these symptoms. So you can easily write about the constitutional symptoms. There are also neurological symptoms, various neurological complications that can be seen in case of ankylosing spondylosis, which are related to the spinal fracture, the fracture of the spine or dislocation, atlantoaxial subluxation that can lead to the spinal cord compression, and quadricular syndrome. The symptoms of this disease are usually first noticed in the late adolescence, What is the age group in which this disease is very common?
Second and
Second and third decade. Alright. So second is 11 to 20 and that is the age of adolescence. Therefore it is said that the symptoms are seen first in early adolescence, in the adolescence and early adulthood. Alright. So the initial symptoms that are present are dull pain, insidious in onset, and felt deep in the lower lumbar or the gluteal region. So it is very difficult to diagnose ankylosing spondylosis in the beginning. In the beginning, you don't get any symptoms. There is only slight pain, dullness in the back, especially in the lower back, lumbar region, and the gluteal region, without any changes in the X-ray. So radiological changes are not seen. And when these symptoms are seen, then at that time the disease has already advanced to a much severe extent. So the pain is accompanied by low back stiffness up to a few hours duration. In the rheumatoid arthritis, there was also stiffness for few hours. But in rheumatoid arthritis, what factors were present? Beta, rheumatoid arthritis. Other than morning stiffness.
more than 1 hour.
It was greater than 1 hour, here also it is more than 1 hour. But few factors that we have to look into for diagnosis of rheumatoid arthritis.
HLA DR4.
Rheumatoid factor. Rheumatoid factor was present in rheumatoid arthritis, whereas it is absent or negative in case of ankylosing spondylosis. Okay. Which improves with activity. Both the symptoms are similar to that of rheumatoid arthritis. Early age onset, the symptoms morning stiffness greater than 1 hour, better by motion. So you can also think of rheumatoid arthritis, but in this case, rheumatoid factor will be negative. Within few months, the pain becomes persistent. Initially, the pain is only for some time, but later on, what happens as the fusion, as the changes in the spine continues to go on, there is persistent pain. The pain becomes persistent day and night, and even at night, the pain is very much severe, and the patient has to wake up and move around in order to get relief from the pain. The nocturnal exacerbation of the pain often forces the patient to wake up, to rise and move about. You have this symptom in a particular medicine. Pain is so severe at night that the patient has to wake up and move around. Just go through your material medica once again and tell me after. I have given you two homeworks today. One is Calicar, 3 things, and the other one is this, the name of the medicine, which has a severe pain, which makes the patient to sit up and walk around in order to relieve the pain. You have to tell me later on. Bony tenderness at the costosternal margins, the junctions, the spinous process, the iliac crest, greater trochanter, ischial tuberosity, tibial tuberculosis, and these may accompany back pain and stiffness. So, apart from the back pain, we have the other involvement of the other joints that causes costosternal junctions. The spinous processes are involved, the iliac crest, the greater trochanters, the ischial tuberosity, tibial tuberculosis, and heels. At these points also the patient may have or complain of pain. Now, hip and shoulder arthritis is considered part of the axial disease. So, whenever we are talking of the axial disease, because this belongs to axial spondyloarthritis, so hip and spine, hip and shoulder are also considered a part of axial spondyloarthritis. Severe isolated hip arthritis or bony chest pain may be the presenting symptom. So in this case, we can also have severe pain in the hip because of the sacroiliac joint, inflammation of the sacroiliac joint, involvement of the sacroiliac joint. Bony chest pain may be presenting complaint. Arthritis of the peripheral joints other than the hip and shoulders are asymmetrical. In rheumatoid arthritis, we had symmetrical involvement of the joint, whereas in case of ankylosing spondylosis, apart from involvement of the axial skeleton, we also have symptoms of the peripheral joint involvement. So this is basically asymmetric. Extra-articular findings. We also discussed about that there will be some extra-articular findings that will be present in the case of ankylosing spondylosis. So extra-articular findings include acute anterior uveitis in up to 40% of the patients, aortitis, aortic insufficiency. So we have anterior uveitis in 40% of the patients, aortic and aortic insufficiencies, GI inflammations, cardiac conduction defect, amyloidosis, and bilateral upper lobe pulmonary fibrosis. So these are some of the extraarticular manifestations that are present in the patient with ankylosing spondylosis. We also have extra or juxta-articular pain due to enthesitis. Now you all know about enthesis and enthesitis, inflammation. There is inflammation at the exertion of tendon and ligament into the wound. Alright, so at these points you can have inflammation. It affects the greater trochanter, iliac crest, ischial tuberosity, and tibial tubercles and the heel. So these are the other places at which we have also seen inflammation. Chest pain occurs from involvement of the thoracic skeleton and muscular insertions. So chest pain is occurring due to the involvement of the thoracic skeleton and muscular insertions. We have enthesitis, which is causing pain. Now, what are the various things that you can examine the patient of ankylosing spondylosis? What are the various steps of physical examination? We can see the tenderness over the joint, look for the tenderness over the joints, then diminished chest expansion. Due to the involvement of the chest, there is central axial skeletal involvement and the involvement of the chest. So there will be diminished movement, diminished chest expansion. There will be loss of spinal mobility. Now, spinal mobility can be checked by doing Chopard test. Alright, this we are going to study in the next slide. Chopard test. There is loss of spinal mobility with a limitation of anterior and lateral flexion. So, whenever you are asking the patient to bend double, standing and touching the hands to the feet, that movement will be limited. So, anterior flexion and lateral flexion and extension of the lumbar spine along with the chest expansion will be limited. So all these movements will be limited because of the fusion of the spine and involvement of the anthesis. The pain in the sacroiliac joint can be elicited either with direct pressure or with stress on the joint. So pain in those joints you can elicit by either applying pressure or by putting them in stress. Diminished anterior flexion of the lumbar spine is done or is checked by Chopard test. Now what is Chopard test? This is basically Chopard test. You are asking the patient to stand first. Then at this point, alright, what is this point? This point is, now what you are doing, this is the measure of lumbar spinal flexion. You have to check for the degree or the extent by which your spine is extending. What you do in this particular test, this patient stands erect. You are asking the patient to stand erect and then with the heels close together, and two marks are made in case of a patient. The first one is made on the spine at the lumbosacral junction. First one is made at the lumbosacral junction. This is basically a lumbosacral junction, and another mark is made 10 cm above this particular point. Now, when you ask the patient to bend, to flex anteriorly and touch the hands to the feet, then what will happen? Due to the contraction of the spine, these points should move apart. Alright. If the patient is flexing forward, these points are made on the posterior aspect or the dorsal aspect of the patient. One at the lumbosacral point and the other 10 cm above the lumbosacral point. Now, when you are asking the patient to flex, the patient bends forward maximally with the knees fully extended. The knees are fully extended and the patient is touching the hands to the toes. The distance between the two marks, you have to measure the distance between the two marks. If those two marks are greater than 4, the distance is more than 4 cm or 5 cm, the patient is okay. But if this is less, if this is increased by 5 cm, that means the patient's spine is perfectly fine. But if these marks are less than 4 cm, especially if these are less than 2.5 cm, that means there is great spinal rigidity and the mobility is disturbed. There is great severity of this disease. So this is known as the Chopard test. Now evaluation. How to evaluate the case of ankylosing spondylosis. So for evaluation, we have to check for, this is an inflammatory disease. You all know. So in inflammatory disease, what happens to the ESR and C-reactive proteins?
Raised.
These are raised. Alright. So there will be, you have to check for ESR and C-reactive protein that will be raised. The patient will have mild anemia. Iron factor and ANA will be negative. These two factors were positive in case of RA. And both of these factors are negative in case of ankylosing spondylosis. This is a very important factor, HLA-B27, which is the diagnostic feature of ankylosing spondylosis. So HLA-B27 is very helpful in the patient with inflammatory back symptoms but negative X-ray. So if a patient is coming to you in the early stage and you suspect that the patient can have ankylosing spondylosis, then go for HLA-B27 in order to diagnose the case in earlier phase. Alright. In the earlier phase, we were only having slight pain, stiffness with negative radiological findings. But at that stage, if you are doing HLA-B27, then you can diagnose this case much before the development of the pathological changes in case of ankylosing spondylosis. So always go for HLA-B27. Now, radiographs in early stage, these radiographs can be normal. The sacroiliac joints are usually symmetrical. So the sacroiliac joints are usually symmetrical. The bony erosions with pseudo-widening followed by fibrosis and ankylosis. So you also have bony erosions with pseudo-widening and it is followed by fibrosis and ankylosis. So there is fibrosis and fusion of the vertebra. Now, what is the differential diagnosis? What are the various other conditions that can resemble ankylosing spondylosis? The first one is osteoarthritis or the spondylosis. Next is disc disease. Third is muscular strain. Many times muscular strain comes in the patient and the patient presents with backache and other symptoms. Next we have fibromyalgia. Fibromyalgia or we are going to discuss in chronic fatigue syndrome. Okay, in the neurology. Metabolic, infectious and malignant causes of the back pain. This we have to exclude. Different metabolic causes, infectious causes, malignant causes of back pain, and there is diffuse idiopathic skeletal hyperosmosis. So these are the various other factors that we have to consider when a patient with lower back pain is coming to us. Now, what is the treatment? How to treat the patient of ankylosing spondylosis whenever a patient is coming in? In all the diseases of locomotor system, in modern medicine especially, almost all the medicines are similar. We have discussed about DMA-RDS and rheumatoid arthritis. What was the full form of DMA-RDS? Disease modifying anti-rheumatic drugs. So DMA-RDS we are also giving this sulfasalazine and methotrexate. Okay. Physiotherapy is common in all the diseases, all the locomotor diseases. We have to give the physiotherapy exercise. We have to tell you should give supporting aids to the patient. Alright. You have to do the counseling of the patient. You have to explain the patient about that particular disease. You have to give exercise programs to maintain the posture and mobility of the patient. NSAIDs are the first line of treatment, non-steroidal
anti-inflammatory
drugs that are usually given for relief of pain and stiffness. TNF, that is human necrosis factor modulatory agent to improve the disease activity and reduce the bone marrow edema. In order to reduce the bone marrow edema and increase the mobility, TNF modulatory agents are given. Secukinumab is an intranuclein 17A antagonist that is found to reduce the signs and severity of ankylosing spondylosis. DMA-RDS we have already discussed, disease modifying anti-rheumatic drugs. Intra-articular glucocorticoids are also administered in case of more pain and stiffness to reduce the inflammation of the joint. And in case of severely deformed joints, we can go for the surgery. So surgical intervention is usually given in case of the patient where there is absolute fusion of the spine that is causing extreme movement restriction in case of the ankylosing spondylosis. So let's revise the treatment protocol. Number one, very good. Second is third, fourth, next DMA-RDS and next one surgery. So this was all about ankylosing spondylosis. Do you have any query or question about it? Anyone?
बच्चा ऐसे
किसी को प्रॉब्लम एनी इशू related to We have discussed about osteoarthritis, we have discussed about rheumatoid arthritis, we have discussed about ankylosing spondylosis. So, can anybody tell me the difference between the three diseases altogether? Anyone? How can you differentiate? Just tell me few differences of each disease, 2 or 3 differences to differentiate these three diseases, or how can you come to the conclusion of these three diseases? One by one. Just 2 or 3 features that will represent osteoarthritis, 2 or 3 features which will represent rheumatoid arthritis, and 2 or 3 features which will represent this ankylosing spondylosis. Yeah, stand up and speak.
एज के साथ जो चेंज होते हैं वो ऑस्टियोआर्थराइटिस में होते हैं, रूमेटॉइड आर्थराइटिस में वो यंग एज में होता है, और एंकिलोजिंग स्पॉन्डिलोसिस ये भी यंग एज में होता है.
Any typical feature? Very good. Sit down. Any typical feature of osteoarthritis in the radiological finding?
Osteophyte formation.
Very good. Osteophytes. In rheumatoid arthritis,
R factor.
anti-CP antibodies. Okay. And in this ankylosing spondylosis, we have HLA-B27 positive. Alright. So very good. I hope you have understood all these things. This session is powered by digital version 2.0 to VIDYAPEETH University. I hope you are satisfied with my digital session. If you have any query, please mention in the comment box and I'll try to resolve it. So this was all for today. Thank you very much.